Dr. Saleh, for your presence today in our 11th Journal Club of PEM updates or PediEM updates. So, Dr. Saleh Alsaeed, he's a pediatric emergency consultant at King Fahd Hospital of the University Imam Abdurrahman bin Faisal University, pediatric emergency fellowship. He got it at McMaster University and emergency medicine health informatics fellowship, McGill University in Canada. Along with that, he's a faculty development fellowship in emergency medicine, George Washington University, in association with Dr. Sulaiman Al Habib Medical Academy. He will present to us, or he will give us a talk, and we will end it up with a discussion about from data to decisions, how health informatics are reshaping pediatric emergency care. So, Dr. Saleh, the floor is yours. We're not hearing you, Dr. Saleh.
So thanks, Dr. Ayara. Is the slide clear for you, everyone?
Yes, that's perfect.
Okay. Do you see the whole slide?
No, yeah, now it's perfect.
Okay. So first of all, thanks, Dr. Ayara, and for organizing committee for giving me the chance to talk about a topic that is near to my heart and important for every one of us. So before going to deep dive to this topic, I would like to ask everyone to think about the last shift that he did and the last patient to examine. I know some of you, maybe he just finished the shift or going to the shift or have day off. So these are the objective for this talk, and we'll start with next slide. So what is health informatics? And let's go one step back. What is informatics? The term informatics introduced early in 1950, and this is cover of a process of gathering, classifying, processing, recording, retrieval, and disseminating information for utilization as required. While the health informatics itself, it is a medical discipline and subspecialty that involve aggregation of biomedical data and information, aids in facilitation for problem solving and decision-making process, and employ modern information technology. There are some definitions from well-known organizations worldwide. The first one is the HIMSS, which is Healthcare Information and Management System Society. So it defines informatics as integration of healthcare science, computer science, information science, and cognitive science to assist and in the management of healthcare information. The other well-known organization is AMIA, which is American Medical Informatics Association, and define health informatics as interdisciplinary field that study and pursue the effective use of data, information, and knowledge for scientific inquiry, problem solving, and decision making. We'll now focus on what is specifically emergency medicine health informatics, because as you see, this is informatics as a big word. So emergency medicine informatics is the subspecialized field focused on collecting, managing, and applying data to improve emergency patient care and operational efficiency. And we define ourselves as physician informatician, or the physician who is bridge the gap between clinical care and information technology to leverage data to improve patient care, workflow efficiency, and health outcome. Clinical informatics is an intersect between three big fields: clinical care, which focus on patient care; healthcare system, which focus on physician and people; and information technology. One of the theory that well known in the world of informatics is socio-technical system theory. So this theory look at the relationship between social elements such as people, culture, and technical elements such as infrastructure and technology, and viewing them as interdependent part of one system. So not part, there is no one part work alone. So in the previous few slides, we talk about information technology, cognition, data, theory, structure, but we shouldn't forget the most important part of health informatics, which is the patient. and our relation with our patient. So after this brief introduction about health informatics, let's go back to pediatric emergency department. I might ask people, I couldn't see the chat, but just think with me, what are these number means to you? So we have 75, 97, 38, 350, 50, 210, and 40. I'll make it easier. So with this slide, would you appreciate anything from this number? I think, of course, yes. So we have 75 millimeter of mercury. We have 97 saturation, and we have 38 temperature and 40 RR, 200 heart rate. And can you make decision from these data or information? I guess no. So what if I give you this information? So I have systolic blood pressure of 75, and you have patient with 97 saturation on 5-liter oxygen. And there is the 200 is the heart rate in a unit, and 350 and 50 are the reading of glucose. But what is the context? So here is the context. So the first one is a systolic blood pressure for a patient who is a 9-year-old with 1-week history of vomiting and diarrhea. And you make decision, this is most likely he is hypotensive or in hypotensive shock and he needs fluid. The other one is 97 saturation on 5-liter oxygen, present with fever and chest pain. This could be pneumonia or myocarditis. You will think to do ECG and X-ray. With patient who had temperature of 38, if you know the information that he received ibuprofen an hour ago, you will not give another dose. You will consider paracetamol or cooling measure. The same is applied for the other data, the glucose of 350 and the glucose of 50. So the first one for patient with who's known case of diabetic who had insulin pump issue and had normal blood gas. So you guess this one, you will talk to the endocrine or you will just get more history. While the other patient with the glucose 50, you will not wait to take more detailed history. You will start to stabilize because this is 50 in a unit who came with decreased vein output. On the other hand, a heart rate of 210 in a baby who is still crying will not let you make a fast decision. So the previous slide talk about the IKW pyramid. So first we present the data, which is numbers. That means nothing to us to do or make an action on. Then we present information. So we say these numbers are the 200 is heart rate and 50 is glucose. Then we take the knowledge. This is heart rate of a unit who's a cry. Then we apply the wisdom for the low glucose for the unit who is coming to our ED with dehydration. And this is one of the fundamental concepts in health informatics. So it is the DIKW pyramid is a foundational framework in health informatics that describe how raw data evolve in actionable wisdom. Now we'll move to the technology point in ED. And I let everyone think about his own workplace, whatever ED you are working in. Think about the place and tasks that intersect with technology. Let's think about the pre-hospital. So some organization and some hospital, even in Canada, they have website, they display the waiting time. So for patient who's planning to visit ED, he might access the website and get a knowledge how many patient is waiting and what is the expected waiting time. And the registration desk, patient will usually use ID identification, insurance information, and these are intersect with technology. And the triad, there are a function and task is being recorded using technology, including vital signs, chief complaint, weight and height, and C-task category. In the waiting area, we have screens, audio-visual, and overhead paging. In the EHR itself, there are many tasks that can be done by healthcare provider, encounter the patient, documentation, and orders. As a task, also we have communication with other subspecialties, arranging radiology, we have admin issue, we have a trainee, and we have patient. We have a lot of monitors around the bed. So we have vital signs monitor, bedside focus, point of care ultrasound, we have ECG machine, we have consent paper or digital consent that we can make the patient to sign in. Some hospital and emergency, they have dashboard for the patient in the ED. They give the whole idea about what's going on. And we sometimes use digital discharge instructions, handle it to the patient through your QR code or sending the instruction to their mobile. So every step in ED, when you just look around, you will see technology around you. So these are the points that these are some points actually that give you an idea that technology is around around us in each shift. But what is unique about pediatric emergency? So we usually need information for immediate intervention, and we use weight-based for dosing and vital signs, and we have high potential volume, specifically in season, and we have resource limitations if there are crowded ED and full hospital bed for patient who's already admitted. And sometimes we have time-sensitive decision-making for sick patients who are coming with unrecognized diagnosis, like a trauma or seizure or other presentation or cyanosis in immunity. And also we are using real-time patient monitoring, because if we did any intervention in the ED for any patient, we would like to observe the patient, and we need real-time information to make decision. So because of that, the health informatics, there are some tools in the health informatics that can help us making better decision for the patient. And there are a wide range of technologies. We will not talk about all of these in this session, but we will highlight on EHR and a clinical decision support system. So we'll start with a clinical decision support system. So these systems assist the healthcare provider by offering evidence-based recommendation at the point of care. So, of course, you have these tools in your EHR. So anything in EHR that provide alert, reminder, flag, or suggest diagnostic tests are considering a clinical decision support system. But what is unique when someone is going to design or critique or discuss with the IT who build up the project or the EHR? So the clinical decision support system should follow the 5 rights. The first is present the right information. You have patient in front of you. You need to know the right information today, not the wrong information about his family or his allergy. You need to know for example, the vital signs right now. And you need this information to present to the right person. Sometimes in ED, we receive call or we get an alert for a patient in front of us inside the emergency about their insurance information that is not yet filled, or the phone number is not completed. So this is the right information, but presented or being shown to a wrong person. And we need the information in the right format. For example, we need that comes to like pop-up message in the system, not like in the inbox or in the basket where we will not see these messages until the end of the shift. Also, we need these messages to come through the right channel. If you order blood work and the blood work, there is an abnormal or a critical result for electrolytes, for example, and instead of receiving this information by paging or by the phone, you need this alert to be. You need this information to get an alert inside the screen, and you need it, of course, at the right time on the care process. Because what's the benefit of getting right information, but after the patient left the emergency? So alerts can cause fatigue to us because if it is not designed well based on the specific workflow, nobody will get attention. But let's think again, what is the goal of alert? Alert is helping us to avoid error of commission. That means warning the clinician for a potential harm of an action that has been done. If you enter wrong dose of paracetamol for a patient, you should get alert. The other goal is to avoid error of omission, which is reminding the clinician for any of tests if not taken. If you receive a patient with sepsis or septic shock, and the system were able to recognize that you are dealing with septic patient and you forgot to, for example, considering lactic acid level or blood culture, you should get alert for these tasks that need to be taken. So since we talk about data, one of the branch of the health informatics is data analytics. This is a huge topic. So my aim of presenting the coming 4 or 5 slides is just to give you an idea what are the types of data analytics and how these types can help us as informatician when we design the system. And we will take the overcrowded ED as an example throughout the analytics. So generally speaking, the data analytics convert vast amount of health data into actionable insight. That is the goal. And analyze historical data, seasonal trend, and external factor as local events, disease outbreak to anticipate the surge and patient arrival. This could be happen in, for example, during winter season, or if there is outbreak or there is national disaster happening in a specific area of the world. So you will get real-time analysis. So there are 4 types of data analytics, and these types, as we move to the right side, that's when there is increase in complexity. So the first one is this descriptive analytics, and this is answer the question what happened. The other is the diagnostic, so why that event happened, and predictive is if this event happened, what should we do? And prescriptive data analytics will answer what will happen in the future. How do we prevent this event from happening in the future? Let's take the first one. So what happened? So this type of data analytics will focus mainly on the past. So if we apply the concept on overcrowded ED and someone just walk and observe there are a lot of patients in the ED and the waiting time, and he asked what happened. So by using, for example, visual or trends or statistical metrics, we will be able to identify that we are over capacity by 20 patients yesterday in the ED. And the other question will come, so why did that happen? And by using filtering, zooming, data mining, and the clustering to find the pattern and correlation. So what are the risk or causes that lead to overcrowded ED yesterday? And again, this type of analytics is based on the past data and the historical data. When we apply to overcrowded ED, so we think we were over capacity yesterday because wait time increased because the exit flow was blocked by patient waiting for inpatient room to open up. And we call it in the workflow the boarding patient. So boarding patient are the patient in the pediatric emergency or in the emergency who already had an order for admission, but they don't have bed in the ward. So we call them boarding patient. And then we'll go to the predictive data analytics. So what will happen? And this prediction make a sense about the future outcome by using historical data combined with statistical modeling and machine learning. So this will apply trained model to a new data to forecast future outcome. So you have 4, 5, or 6 patients in the emergency, and you know that there are 20 or 50 patients in the ward. So this will give you a hint. So what will happen? So if we apply it in the overcrowded example, so the analysis will predict that similar surge or similar overcrowded will happen over the next weekend or the next 2 to 3 hours, the area will be crowded. Finally, the prescriptive data analytics, which is the advanced type of data analytics, and it's built on diagnostic and predictive analytics to recommend specific action. So it uses optimization algorithm and rules and machine learning to suggest a specific action. So you are sitting in the ED, again, you have 4 to 5 patients right now, and you have a 20 patient in the ward, and the ward capacity, for example, only 30. And so the system will not give you an alert that you will be busy, but also suggest an advice for you. So how do we apply to overcrowded ED? So the analysis will suggest, for example, to direct ambulance and referral to other hospital instead of drop sick patient to your ED. That is, in summary, the data analytics. And as we move from descriptive to perspective analysis, the more technical and machine learning and AI models are work in the advanced type of data analytics. Because these are beyond the human ability to make decision and perspective. So what should I do? So we need technology to help us make decision by analysis the current situation and getting the benefit from historical data. So moving to electronic health record. So I'm sure, I'm hope, and I'm sure like everyone is working in working with electronic health record and not in a paper work. And maybe some of us in early years of residency, we use the paper work. So for me, I during early years of residency, maybe the first 2 years, we were charting on paper. Then after that, we moved to the electronic. So at least for me, like as a informatician, I have the insight how is the world now after the paper. So EHR is digital patient-centered record that store comprehensive health information, including medical history, diagnosis, medication, and lab result in real time. And the successful implementation of EHR in emergency require a multifaceted approach. This will address technological, organizational, and the human factor. And I like to focus also on human factor because if you build the best EHR in the hospital without considering the design and how does the human interact with the system, ultimately you will not get the full benefit from the EHR. And we are doing that by something that we call EHR usability. So there are 4 or 5 items in the usability. We call it usability testing. So these items test each EHR that's being implemented based on its function. The first is learnability. Think about when you did a rotation in other hospital during residency or fellowship, and first time somebody sat beside you and explained to you, listen, this is the icon that you will log in, this is where you write it, your documentation, this is where you put the order. So the system should be relatively easy to learn, not a complex. Second is efficiency. So because again, when you have an excellent EHR, but that take you a long time to achieve task, this is less efficient. So experienced users should attain high level of productivity by using the EHR. The third is memorability. So the feature in EHR it should be easy to retain once learned. So you didn't need to ask again, oh, I forget how to, for example, execute order or to write discharge summary or making a consultation in the system. Finally, the error. So the system should be designed to minimize error and support error detection. If you put abnormal, for example, by mistake, high dose for amoxicillin or paracetamol, so the system need to be designed to minimize this order and errors. Finally, the satisfaction. And the user experience should be like subjectively satisfying from using the EHR. either by giving the access from different device or the system itself is able to be accessed outside the hospital. So these are, we call it usability testing of EHR. So each EHR that you're gonna work on, think about these items before critique. Just this is, I like this EHR or I don't like. So we have to be objectively criticize the EHR. We'll talk about this is the third part of this talk about cognitive bias. Again, this is another interesting topic that attracted me during the fellowship and during the work in the informatics. Is cognitive bias. And I ask myself, why does bias happen in decision making? So in answering this, let's think about the main function that we do in ED. So we are dealing with diagnosis, and diagnosis process is a complex process. And why the diagnosis process is complex? Because it is an iterative process, not linear. So patient is coming to us in ED, and we collect information and doing history and doing examination, ordering blood work, and getting some clue. This is most likely a patient with abdominal pain and normal glucose, maybe gastritis. Then you ask her, then you did another blood work, and you found that the blood gas, for example, abnormal, or patient is in the KA. Then you think this could be an early diagnosis of an early presentation or of diabetes. And also there are incomplete data that evolve over time. So as you order more labs, you will end up having more results and ending having more differential diagnosis. And there will be continuous hypothesis generation. With each new result or new image result, for example, we are ordering CT head for a patient with head trauma, or imaging for a patient with suspected fracture. So sometimes by history and examination, we think this is most likely a positive or negative image, but we are keeping continuous hypothesis this generation until we get final result from the specialist. And also the diagnosis process involves uncertainty, and this could be related to patient comorbidities or the disease pathology itself. And finally, the most important, there are external factors like stress and noise and fatigue. So these are factors make the diagnosis process as a complex, and ultimately making us falling in bias during our decision making. One of the processes that address these cognitive bias is called dual process theory of thought. And this is a psychological process. Look at the making decision as a balance between two systems. System one, which is fast, intuitive, that prioritizes speed over accuracy. For example, you just saw a patient in ED and you talk to your colleague that I have seen this patient many times before. For example, he's always coming to take nebulization and leave. Or you say to yourself that I have gut feeling about this person. I think this is most likely a child abuse case, without getting detailed history or examination. Or you, at the end of your shift, you handed over the case to your colleague and you just mentioned, listen, this is another case of gastro, without getting details, history and examination, or even looking or reviewing the last blood work that you order. That is the system one. System two, on the other hand, is slow and analytical and require more effort and time. So again, in this process, in this theory, so they are looking at the patient presentation. So if the presentation is known to us, usually we will activate type 1 process. If the clinical presentation is not known to us or not recognized, and could be related to early years of practice. If you haven't seen many cases of trauma or resuscitation, this is most likely the presentation will be not recognized. Or for the junior physician who haven't seen a lot of cases. What happened that over time, if the case or the trauma or the junior physician have seen similar presentation over time, he or she will build pattern recognition and then will activate type 1 process. And here is the risk of bias can arise. So what will be the function of type 2? So type 2 thinking, they do a great job, something that we call rational override. So you walk in the ED, you saw a patient with abdominal pain and vomiting, and you think this is most likely gastroenteritis. Then your colleague ordered blood work, and before leaving the ED or handover, you just get an alert from the system that there are a new lab results came out. Nobody acknowledged these results. And you found that there are, for example, abnormal electrolyte or blood gas. So this is what we call rational override. And here is the debiasing strategy work. There are a lot of debias strategy, but the most important strategy is the informatics tool, like the tools that we already mentioned about, we talk about, like a clinical decision support system, alert, and better communication with healthcare providers inside the system. Finally, we'll talk about clinical workflow. So we talk about health informatics as a knowledge. Then we move to the tools. Then we spend some slides about data analytics, and we identify why we are falling in bias. Now, if we want to design our workflow, we need to understand our current workflow. I mean, physical workflow. So, what is workflow? Workflow is a process involve a series of tasks that performed by various people within and between work environment to deliver care. Application of a clinical informatics tool required prior clinical and IT workflow optimization and physical also workflow optimization. So if you want to implement a new workflow in the system and you decide with your colleague that let us optimize, for example, discharge instructions that we use to send it to the patient through the EHR. Or for example, let us optimize the medical directive that can be given to the nurse triage. For example, if patient came with vomiting or patient came with pain, medical directive will tell the nurse to give medication without getting back to a physician. This is what we call medical directive. So if you want to implement medical directive in the triage room, you need to know what's going on. How does the patient arrive to the triage? So if there is no patient, if there is no nurse covering triage for a period of time, for like 10, 15 seconds, how do we optimize this gap? So you have to align clinical, physical, and IT workflow before implementing an idea. And there are many reasons why the environment of workflow implementation is also so complex. Because in emergency, there are multiple providers. You came in emergency, you will see physicians from different subspecialties, RTs, nurses, sometimes admins, as well as patient and their family. And also there are varying level of communications. So you are communicating with your colleague in the ED, with the patient, and with the resident and learner, with the admin, and with subspecialties. And there are high volume of workload. So you have to finish your documentation, you have to review the result, you have to enter sick leave for a patient who's asking for sick leave, and you have to answer the call from a critical result that's coming out either from radiology or lab. And there are multitasking, the same sort of example that I already mentioned. And there are interruption. And think about your last shift again and last patient. So how many times you have been interrupted either by the patient or by the other healthcare provider during providing a care to the patient. So again, when physical and clinical and IT workflow being aligned, it will increase the likelihood of positive healthcare outcome and diminish error rate that could happen if workflow was implemented. Concluding the topic of workflow, I'll give you an example that about the an idea that we implemented in our hospital. So we observed that the time taken for patient who is presenting to our emergency with wheeze, the time taken to enter medication take longer than what should it be. So the whole project that has been implemented started with one word: observation. And if someone asks me about what is the most skills that I need to know to be a health informatician or physician informatician, or even the flavor or thinking of being informatician, is observation. We just observe what's going on. Sometimes there are chances and events that happening around us and nobody observe. So once you observe, you will go to the other steps. So that was the observation. The time is longer than should it be for a patient who was coming with asthma. So what did we do? So first we analyzed the current IT and physical workflow. So we start with IT workflow. We look at how many steps that need to be taken for a patient who needs only Ventolin and oral steroid. And you can see there are 26 steps, and the steps here means either click or text in the system just to deliver this Ventolin and oral steroid to the patient. If patient is more sick and he required an extra medications, steps increase and to 32 steps. If patient is more sick and you need to involve or include IV steroid and magnesium sulfate, it is 40 steps. Keeping in mind, these steps is not including documentation, labs, or imaging, or even referral to the subspecialty. So these are only to deliver medication. And that's a lot for a quite common condition. And I know we are in summer, but a few months from now, winter is coming, and you will keep entering these medications frequently. Then we analyze the workflow. So we ask ourselves, how is the patient is coming to ED with wheeze, and he will take the Ventolin. So we utilize something that we call design thinking. So when you empathize and you just take the journey by yourself. So I sat with the patient and with the nurses and said that what are the processes that need to be taken by patient? So patient is getting registered in the registered area, and he is coming to us in the triage room. On the left side, there are books with multiple lines, multiple arrow, and different color. So there are people, physician, patient, nurses, and there are movement. So this is the space where the patient is actually moved. And there are tasks. So patient coming to after finished registration, he will come to the triage nurse to the triage area, and the nurse will did quite 11 to 10 to 11 steps in the system. If patient is not in distress, he will be placed in the waiting room. If he is distressed, he will be immediately placed inside the emergency department. What will happen after that? Let's see. So I will not go into details explaining how things goes. My objective of showing the process is that you need to build your own workflow based on your organization structure. You need to understand which door is patient coming in, at what bed usually patient will be placed, if medication being ordered and not available in Omnicell at your ED, what will be the next steps? If you put a wrong order, what will be the process? Who is gonna give alert to the physician, the nurse, or the pharmacy? So we like after we draw the physical and the clinical workflow, we get surprised. So for me, I get new information. Although I work in the hospital since 10 years during pregnancy, during the residency and fellowship, and after fellowship, I noticed that if medication is not available in the ED, the nurse will leave the department to get that medication from the pharmacy store, because that medication need to be signed by nurse. So we cannot send, for example, a porter or housekeeper to bring that medication. And this is ultimately will affect the whole workflow in the department. After that, we sit with the stakeholder. So we talk to the chairman of the department, head of the unit, and Bolmo unit and RT. We review the current guidelines, and also we talked about with the IT to know the capability of EHR to accommodate the order set for asthma. Then we draw or design the order set with pre-selected medications. Then guess what happened? I'll show the video here. So in the picture up, on the upper side of this video, this is the order set. This is the time taken for the order set after implementation. It was 45 seconds. 45 seconds. Before the order set, the time taken to achieve the task was 160 seconds. So now there is a drop by 50%, more than 50%, from 160 seconds to 45 seconds. Less steps and right dosing and correct order, and will decrease the work overload for physician. And instead of calculating how many, for example, based in your organization, the dose of DIXA is 0.6 milligram per kg. Some hospital use 0.3 milligram per kg. So if you, for example, multiply 0.6 times a patient with weight of 19, definitely you're going to use the calculator to calculate that dose. While once the order set implemented, it is automatic calculating the dose for the patient in front of you. And this is the beauty of informatics. And so that is the project that we work in. Finally, this is the outcome. I'll take some take-home messages. So, like fast recap of the things that we talk about. We talk about health informatics is the science of using data, information, and knowledge to improve care. Physician informatician, or people who like to improve the care of their patient by using technology. They actually fill the gap or bridge the gap between clinical practice and information technology. Always a question and explore the capability and limitation of EHR. So before implementing the order set of asthma, some of my colleagues were believing the system will not accommodate these order sets. And the system will not allow to calculate the doses. And the system might not accommodate the pre-selected medications. So always question and explore the capability of EHR. There are many capabilities. It is like someone if he's buy iPhone or a new phone, and he used only 2 to 3 functions, and he doesn't know about multiple capabilities. It is the same thing applied to EHR. Again, it is a technology that we need to take the full benefit of. Finally, that your primary focus should be the patient, not the electronic system. If you get many sick patients with asthma and you put this order, most of your time will be spent caring for the patient, knowing the ultimate pathway of the patient. Is he going to be admitted? Do we need to order blood gas right now? Do we need to shift the patient to crash area? Do we need to call ICU right now? And instead of just calculating and entering the dose of Ventoline and steroid. So my next slide is just to ask everyone, like, think about your last shift and last patient you saw, and ask yourself, what could have been done better if digital resources had been utilized? And thank you.
يعطيك العافية. Thank you so much, Dr. Saleh, for this great, insightful presentation and very comprehensive. And I would really congratulate you for the great, amazing project, or let's say a quality project that you have been done in your hospital. It's amazingly, by only a set order has been reduced by 2 minutes from the beginning, which is really amazing. And every minute it's been counted in our AD. If there's any questions from the audience, they can write it in the chat. From my side, I have a couple of questions, if you don't mind. First question, as a pediatric emergency department, increasingly they are relying on the real-time clinical decision support system. How do we ensure these tools enhance rather than interrupt the frontline clinical workflow?
Yeah, so that's a good question because there are some parts I didn't explore, which is the downside of these tools.
Mhm.
So the downside is the first of all is to know your workflow and design based on your current workflow. And second thing, the very critical point in using these tools, because we talk about these tools like technically used by expert person. So if you're gonna use asthma order set, or even we build multiple order set like sepsis and status epilepticus. So you are the experts, and you will not order all the medication of patient who's seizing in front of you that's listed in the order set.
Mhm.
While if there is junior physician and he is like he doesn't know which medication need to be used, and he saw order this order set, he will just click and these clicks will be executed. So how did we solve this problem? We
Mhm.
solve it by pre-selected. So and that project, as you see in the right side in this slide, so we did not select all medication. So pre-selected means that when someone open the order set, there are pre-selected medication that can be used for any patient. The same thing for septic patient who's coming to the ED, or
Amazing.
like a sickle cell patient. We don't need to order all the labs. So we select, for example, CBC and renal function test. We did not select blood culture and
Mhm.
some labs that need we call it abuse. So we want to avoid abuse. Like one of the tools is just to avoid pre-selected check for the order set. Just use the one that can be saved entering for all the patients.
Yeah, so you make it as a default choice for most of the order set. Okay, that's really a smart thing to be done in order set and among the hospitals to reduce the bias, as you have mentioned, plus the junior residents who's working with us as a trainees, instead of ordering all the labs and the medications that doesn't need it for the patients, so we're limiting the choices. That's really amazing idea. So another question, again from my side, there is often a disconnect between physical ED workflow and IT infrastructure. From your experience, what are the most effective strategies to bridge this gap and achieve meaningful HR optimization? Because I'm facing that actually with the IT, especially IT people and the infrastructure. It's not that helpful to reach the excellence of our epic systems, and for example, in our hospital. ف, what's the bridge or the strategies that it will help us to reach the excellent optimization of our HR?
Again, I would say it is the same slide. Just it is communication.
Mm,
So before we give this plan to the IT or and the pharmacy, I sit with them. I just communicate with them. Like
mm,
I told the people in the IT department, can we just put these medications in the system directly? And the issue was the weight, because our issue in pediatric is the weight-based dosing.
exactly.
And the answer was from the IT guy. He told me, listen, if the weight is being entered correctly by the nurse, we are okay. And this is should be like basic with any patient who's coming to our ED, is to put the weight before putting the medications, like in the most of the cases. And I would say just the first one is communication, optimize communication. People, they have a lot of effort, they are smart, but sometimes we are as physician busy, and we think that IT people, um, they don't understand medicine, so we do need to involve them about what asthma or sepsis workup. The same things with the IT people. They are smart enough to like design and click, because they are using algorithm and the steps based on the IT. They are, at the end of the day, this is a program. They need to design the program, but
Yeah.
actual in reality, they don't differentiate between like ECG and head CT scan. Both of these things for them is an investigation or an image, like CT and chest X-ray. They are an image or MRI. So they read it as they think about the urgency of these three orders as at the same level. But for us, no, like CT or X-ray, much more important to have these in our system in the ED rather than showing me an MRI, because nobody like unlikely to order MRI directly or urgently from ER.
Mhm. Amazing. So it's a crystal clear about communication, keep in touch with them in order to achieve the excellence optimization of the HR. Cannot agree more. I think Dr. Salim, he's raising his hand. Salim, you can.
Assalamu alaikum, يعطيكم العافية. I was about to write my question, but I'm driving currently, so I think it's safer to ask it verbally. أول شيء يعطيك العافية, Dr. Saleh. I think fabulous lecture, and I think a lot of us should really understand these processes and workflows in order to be able and capable of making a change. لأنه أكثر الناس, they think about an idea, how to implement it, but they get stuck on how to execute it. ويمكن آخر نقاش هو اللي خلاني متحمس إني أشارك إنه how can we have an optimized communication with IT and other services. وأنا أعتقد إنه من أحد الأشياء المهمة جدا لنا كأطباء, سواء if we are pursuing informatics as a career أو as an interest, إنه two things. So one, we need to have physician champions في كل department, بس خلينا نركز اليوم على البيدياتريك ED. انه in pediatric emergency medicine يعني ممكن الدكتور صالح السعيد هو الاكسبرت and the subject matter expert, بس اتوقع ما حيكون متواجد ناس مثل الدكتور صالح السعيد في كل طوارئ اطفال. So what's the solution? It's actually if we have a selection criteria for a physician or a group of physicians in a small group or a small health system who understand some informatics principles, وهذه تكون بالشراكه مع الشركه اللي تقدم الخدمه, سواء EHR ولا اللاب انفورميشن سيرفيس ولا الايمج انفورميشن سيرفيس, بحيث انهم يكون عندهم القدره على عمل بعض التغييرات. وهذه النقطه الثانيه. النقطه الثانيه انه we need to have these physician champions with some capability to make change themselves. لانه احد الاشياء, وانا اعرف تجربه الدكتور صالح في التجربه هذه, انه عانوا كثير في التواصل مع ال EHR vendor because they have everything locked in, which is vendor lock. أعتقد إنه if you are interested to pursue such a change, تتواصل مع قيادات المستشفى بحيث إنه يعطونكم leverage كphysicians, إنه we need to have some capability to make some changes in the system as much as we can as a physician. So I don't have to go all the way to the IT service, to the vendor, and ask them to support us with some projects. And most of them, زي ما قال دكتور صالح, they don't understand medicine, so they are purely IT. So it becomes very challenging and it will take a long time.
Yeah.
A project that is like two months old, it will take probably a year and a half, because there is this really bad circle of communication. فأعتقد yes, physician champions, and also engage with leadership at the health system to allow these physician champions to be able to make changes. يعني الاوردر سيتس, الاشياء اللي لها علاقه بالبريدكتيف اناليتكس, بالبروسبكتيف اناليتكس, اعطونا بعض القدره انه نقدر نسويها internally. And a project that is big and huge, you can complete it within 4 to 6 months instead of like a year or two. يعطيكم العافية. شكرا جزيلا.
يعطيك العافية Dr. Salim. Thank you so much. And yes, I totally agree with that. And I think that it's one of the great ideas that we have to tackle it, either to build the champions in our ADs and also to get a proper communication with the IT as a chairpersons and leaders as well. Thank you so much, Dr. Salim, for the comments. Any questions from the audience? Okay, last question from my side, Dr. Saleh. I don't want to delay it further. With the growing use of alerts and pathways and AI-driven informatics, so tools in pediatric emergency care, how can we minimize the pitfalls such as alert fatigue, bias, and over-reliance on tech while still improving patient safety? I think you have mentioned a little bit about it in your slides, but I would like to know if there's any strategies about it.
Yes. This is actually going to be like growing issues in informatics, because most of alerts, they have false positive. So like technically, like 70% of alerts is not being is the wrong alert, or will not makes you making a decision. But if you alert will let you will save your life and will save the patient in front of you. And this is one of the solution is when some like proposing specific EHR like design in emergency, you need, for example, to take off some options that already being shown to the physician. For example, I'm a physician in pediatric emergency, and I utilized 5 to 6 common medications. Rarely, for example, I order like a Kebra medication for a patient with seizure. So that medication or that test should not be in the list when I search for a test. And the main answer for that is, again, for design. So one of the big branches in informatics is human-computer interaction and how to design the system. So designing the system this is one of the areas being taught and used in other industries for food application and delivery and other applications, and need to be applied the same to our industry. So by just setting and design, so you need to ask yourself and talk to the IT about designing. Listen, this is my workflow. These are the most cases that I'm going to see, and I want just please put these orders medications in the first few list when I just click the drop list.
That's amazing. Okay, so I think by this we can conclude, Dr. Saleh. Allah Yasadik, thank you so much for your time, for your efforts. This is a really great, insightful talk and discussion as well. Dr. Salim, he's giving us a really insightful comments. And I would like a special thank to our audience for their presence today and joining and participating and enriching this discussion. And see you, inshallah, in our next PediEM updates. Thank you so much, Dr. Saleh.
Thanks. شكرا.
يعطيكم العافية.